Hello everyone. Today we will be studying the complications of cardiac catheterization. So there are three complications of cardiac catheterization. Number one is the AV fistula, number two is a pseudoaneurysm, and the third one is hematoma. The Uworld ID for this is 12282 for step 2 CK Uworld. So what is the etiology behind AV fistula? The most common cause is trauma. The second cause, which is usually encountered in the boards, is as a complication of cardiac catheterization. Most common site is the femoral artery. So what happens that when femoral artery is being accessed, sometimes the femoral vein is punctured, and this leads to a communication between the femoral artery and the femoral vein. And if not adequate hemostasis, that is the pressure applied after the procedure, this can lead to continuous flow of blood from the artery to the vein due to difference in pressures, which lead to development of AV fistula. What are the risk factors? Now, the risk factors for AV fistula, number one is the sheath placement. So whenever the cardiac catheterization is done, usually a sheath is placed, and this sheath, when it's placed, it can lead to dilation of the tract between the artery and the vein. So more larger the sheath size is there, more larger the dilation of the tract will be, and there are more chances that it will not close spontaneously. Second thing is that if the femoral artery is being accessed distally, that is after the bifurcation of the common femoral artery, usually it is during the access of D femoral artery. So the profunda femoris vein, it passes between the profunda femoris artery and the deep femoral artery. And if this profunda femoris vein is punctured during the access of deep femoral artery, what can happen is that it increases the risk of development of AV fistula. So what is the typical presentation of arteriovenous fistula? Usually it is asymptomatic initially. So if the question comes out that the person was asymptomatic initially, then yes, the patient is, because initially it takes time for the fistula to develop. After that, slowly there is leakage of fluid through this connection into the surrounding area, which can lead to development of the swelling, and then the cytokines are there which can cause localized tenderness and pain. The murmur is continuous because the pressure between the artery and the vein is always different throughout the cardiac cycle. So there is continuous shunting of blood from the artery to the vein. So it's a continuous murmur. Then the thrill is palpable. Now what happens is that when there is increased blood flow through this fistula into vein, the distal artery has decreased blood supply. And when there's decreased blood supply, it leads to decreased distal pulses. Second thing what happens is that when more is blood shunted to the veins, then this leads to high venous pressures. And high venous pressure leads to retention of the blood in the veins. What happens as a result of that? It pools down and it can lead to lower extremity edema of the affected site. And a very important board topic tested is the high output heart failure that presents with symptoms of tachycardia, high ejection fraction, pulmonary edema, and shortness of breath. And it usually develops due to increased shunting of blood through the AV fistula, and there is increased venous return towards the right side of the heart, which ultimately leads to increased blood in the left side of the heart, and as a result, this leads to high output heart failure and more blood in the pulmonary circulation, which leads to pulmonary edema. So, when they give you a typical presentation of AV fistula, the thing would be, what's the best next step? So the best next step would be given different treatments that we will discuss later part of the presentation. But even when you have a strong clinical suspicion of AV fistula, you always do a diagnostic test. And the first line investigation is the duplex ultrasound, and what it shows is mosaic color pattern. If they say that the ultrasound was normal, but the clinical suspicion from the case presentation is very high, then alternative investigations that you can do is a CT or an MR angiography. It can clearly demonstrate an AVF. One of the investigations that was done earlier and is characteristic for the AV fistula was arteriography. It usually shows a blush with rapid opacification of the adjacent deep vein in which the blood is being shunted from the artery. But nowadays it is not used, as if you see an AV fistula diagnosis from duplex ultrasound, you directly proceed to the treatment and other investigations is not needed. The treatment is very important. So if there is a small asymptomatic AV fistula, you only do observation. You observe that, and next question comes, when you will repeat the ultrasound. It's after 1 month. Then when you decide that you have to intervene for an AV fistula, the most important and the most common is when the clinical symptoms develop. What are those? For example, there's increased diversion of blood flow from the artery to the veins, and it will lead to decreased blood flow in the part of the artery distal to the fistula, which will lead to symptoms of ischemia and claudication, that is pain on exertion. Second thing, if there is venous hypertension that develops, which leads to pooling of the blood in the veins, presenting as signs of lower extremity edema or venous insufficiency, like varicose veins. Third clinical symptom, if heart failure develops, that is high output cardiac failure. The second indication is if you were doing ultrasound surveillance after each month and you are seeing that there is progressive enlargement, then you typically go for intervention. Third is if the large AV fistula is there, that is usually as a result of stab, a gunshot, or any projectile injury, and it's very large, then usually you do not monitor that with observation because it has very high chances that it will not heal on its own. Fourth is if there's iatrogenic AV fistulas that you make on your own, for example, for hemodialysis, and they do not seal spontaneously. Typically, we consider intervening if it persists for a year. So for iatrogenic, it's 1 year, and for acquired due to trauma or catheterization, we consider 3 to 4 weeks. What are the interventions that you can do? The first intervention for any AVF that is symptomatic or that persists beyond 3 to 4 weeks is an image guided therapy, that is ultrasound guided compression. You put the ultrasound probe over the AV fistula and you try to close it with compression. Remember that when you are trying to compress the AV fistula, you give sedation, and you have to abandon this procedure if, even after giving sedation, the pain is not controlled. The second intervention is surgical repair that you do when there is failure to seal by compression-based therapy. If there was failure of compression-based therapy of AV fistula and the person cannot tolerate bleeding, for example, there is any blood thinners the patient is using, or a genetic coagulation defect. Second, if the person has a hostile groin, for example, lots of scarring because he went for a lot of prior surgeries. A third thing, if the patient has a high risk of general anesthesia, then you go for endovascular repair. It can be done with a covered stent or coil embolization. This question is a lot of times asked about AV fistula, that what's the prognosis of that? So after repair, it is excellent, and if they say that there were any physiological derangements, so after repair, they correct on their own. So the prognosis is excellent. So this was our discussion about AV fistula. You can see that this is from the Uworld ID I mentioned at the start of the presentation.